Pedro, thank you so much. My first observation is how common this is. So, as I searched for an appropriate case here, so certainly in a week there were 3. And so I've selected which I thought probably has the better teaching point here. Mm-hmm. So 77-year-old male with 1 hour of severe crushing chest pain bought at 10:30 in the night via ER, pretty good response. And clearly by EKG, I remember driving there and I'm telling them, look, pull out a JL4 guiding catheter and choice PT extra support. I mean, it's evident what the culprit is going to be. And here is the culprit. The question is that thrombus in the, a little problem here going to the previous view, was there thrombus in the mid portion of the LAD or it's some calcification? And the other point which over years of doing it again and again, often you're rushing to do a STEMI, looks straightforward, it's going to be LAD and let's put in a guide and get over with it. Yet again, I look at this case and I tell myself, look, there is always so many benefits of knowing the entire anatomy. Takes you just a moment, take a picture of the right, and once you take a look, now I'm already thinking, as I'm doing the LAD, that look, is this something also I need to address today? And which is, I think, the entire purpose of this conversation. I think data and including the complete trial has demonstrated that you need to do the non-culprit. The question is when? That to me is the real issue here. So we have a culprit in the LAD and of course significant disease in the right, and let's see what the approach should be. So far as the data, not much doubt. A couple of papers, but this one is really leaves no doubt. Recommendations all becoming much clearer after that, that in the presence of additional disease beyond the culprit, the question is more of timing, which is specifically outlined in their summary slide I'll show you in the next one. But once you're looking at the data, whether it is a primary endpoint or the secondary, clear benefit of doing a complete revascularization for patients presenting with STEMI. And here it is, and if you look at it, performed either during the index hospitalization or soon after discharge. And once you piece it through and take a look at a couple of editorials, the optimal time actually was defined by the editors at 2 weeks. So back to our case. Straightforward, 2 options. Option 1 is bring the patient back for stage PCI of the RCA in a few days, but during the same admission, which is what was done in the majority of the cases. Or, why you give him some time to recover from his MI, why give more dye, although this patient's renal function was fine. Bring him back in a few weeks and take care of the problem with the right. And the option 2 here was, look, the LAD didn't look difficult at all, straightforward, and why not take care of the RCA at the same index sitting? And that's where I think there are a couple of lessons to learn, and so I'm running this in my mind, and sometimes in Miami, the decision becomes straightforward. So this is amongst my 22 years of doing STEMI in Miami, 41% of patients have no insurance, and this patient makes it much easier. So, would you want to wait the next day? Probably, but I'm pretty sure in the meantime I'll get another call from the administrator, and there are all sorts of reasons. So I think in this particular case, with both options being clear, with the real message here being that in the desire and pursuit of chasing the second lesion, don't mess up. So if it's looking something much more complicated, I think you're clearly better off bringing the patient back subsequently. And so with that, here is his index lesion. Again, the mid portion of the proximal and the mid portion prior to the diagonal there. I'm not certain if that's calcification or thrombus, but I often use a lot of aspiration, maybe more than what I should. But in this case, so this is the right coronary artery taken. And here it is, the wire kept going into a small diagonal. I think I reposition it, put in a 2.5 balloon, and it's restored flow. And at this point, I'm not sure if I can get both the lesions. I move into more of a areocranial view. There is also a little distal left main there, and have a much better sense of the sizing. And this is, I think, a 3.0 or 3 or 3.538, and good enough result. And so this is fixed. And at this point, I decided to take a little better picture for the circ. Looks everything okay, but you see a nice TIMI flow, good blush, and you also start seeing a filling of the distal part of the right coronary artery. So at this point, over the years, I have given myself a couple of straightforward rules that, look, if I'm going to be trying a second vessel, I'm going to do my best to use the wire which I had used before and use the balloons. So it kind of tells me that, look, the lesion probably isn't that rough. So here is back with the right coronary artery, view with the AP cranial to open out the PDA there. And but this was a little more challenging what I thought. Almost felt as if it's a subtotal occlusion, as even suggested by the collaterals, and getting the wire was more harder than what I thought, but the little more persistence, the wire is there. That's the same 2.5 balloon which I had used for the LAD, and a few more dilatations with that, and it's a pretty impressive, very large right coronary artery, I'm sure, contributing significantly to the ischemia. And from there onward, it really is a straightforward case, a long stent here and another one there, and that's the final result. I think I gave some more nitroprusside to augment the distal microvasculature flow. Now you can again cross it, put in an export catheter, but I think that's where the chasing of perfection in this second lesion, I think there is no purpose to it. You've already opened the culprit in the LAD. The patient's primary purpose of primary PCI has been achieved. Here is another picture just to demonstrate the excellent blush. And the patient was transferred overnight to the intensive care and went home the next day. I don't have a follow-up. This was just done 2 weeks ago, but I have no doubt the patient is doing fine. So in summary, here are the conclusions. I do believe that as we are confronting these patients more and more, it's going to be really your judgment. Should you, first of all, stage it, give it a couple of weeks, a few days, or maybe do it at the same time? I think we'll be doing a lot more of these procedures at the same setting. The equipment has become so much better. Thrombectomy devices have become better, and yet I think it's all a matter of good clinical judgment. You can have early discharge cost savings, but I don't think every patient should be done at the same sitting, and therein lies, I think, the final message of Complete, which I don't think is kind of talked as much, that not only do you need to just have an angiographic follow-up, I think using clinical judgment to do the second lesion is important. Thank you.
Fantastic, fantastic. Dr. Mehta, thank you so much for the beautiful example.